This meeting is being recorded.
Today's webinar, Maximizing the Benefits of Your NEMT Program to Have the Greatest Impact on Patient Health, is brought to you by MediDrive. MediDrive is an MHPA partner and great supporter of MHPA and our member health plans. They will also be attending MHPA 24 next month in Indianapolis. We hope to see you there. I want to thank their entire team for putting together today's session. We have a great group for you today speaking about a very important subject, non-emergency medical transportation, or NEMT. As you will likely hear during today's panel discussion, NEMT can be a critical factor among social determinants of health. So let's get to it, and let me introduce today's moderator, Scott Law. Scott has served as a senior executive leader of several industry-leading publicly traded managed care organizations that deliver managed healthcare services through health plans and government-sponsored plans. Most recently, Scott was a national SVP of healthcare services for Anthem Healthcare. Scott, it's all yours.
Thank you so much, Patrick. It's an honor to be here with all of you today, and I appreciate that introduction. I have been in the healthcare industry for 4 decades now. With that, let me start with a really warm welcome for all the MHPA members and other guests who are able to join us today. We've got some important ground to cover today, and one that touches many health plans, providers, members. In fact, research has shown that without a vehicle and viable public transportation, 1 in 5 Americans miss needed health care, impacting members' care, costs, and quality outcomes. So let's jump in here. Let me begin with an introduction to our panel. And please, each of the panelists, tell us a little bit about yourself before we get started. I'm going to begin with Alan Murray. Alan is the president and CEO of MediDrive, which is a new entry into the NEMT arena. Alan, I'm aware that you have a very interesting background in a number of areas of healthcare. What made you decide to enter into NEMT and start MediDrive?
Yeah, thanks, Scott. And also, thank you so much for being the moderator and hosting here. I know we're going to have a lot of fun today talking about this subject. You know, my background since I came to the US in 2002 has all been healthcare related. I was in health insurance in various different capacities, up to including being the president and CEO of Empire Blue Cross Blue Shield, the largest health insurance company in New York. And quite frankly, Scott, I found it incredibly kind of difficult to understand the transportation industry as it related to healthcare, right? It's something that Medicaid plans, Medicare Advantage plans, and a supplemental benefit provide to their members. And for me, it was kind of a line item as a health insurance company until I started to really understand, for example, the statistic you said, 1 in 5 people struggle to get their appointment. It really started to occur to me that something has to be done here. If we're going to have a true impact on people's healthcare, then we have to get them to their appointments, right? And how do you do that, and what is the impact? And so I joined MediDrive, partnered with a company called CTG, Corporate Transportation Group, who has been in the transportation industry for over 40 years. And our view was to combine an incredible history of transportation, of technology, and healthcare to really have a material impact on the trust, the reliability of people actually getting to their providers' offices and getting care. So, Scott, that's my passion. That's why I joined MediDrive, and I'm really excited for the rest of this panel to introduce themselves and for us to start chatting it through.
Thank you, Alan. Next, we have Brett Friedman. Brett is a healthcare attorney at Ropes Gray and a former New York State Medicaid director. Brett, tell us a little bit about yourself.
I mean, what else is there to say? No, that's a good intro. I'm a currently practicing healthcare attorney. Been a lawyer my entire career, except for about a 3-year period where I had the privilege of running the New York State Medicaid program, mostly over the course of the COVID-19 pandemic. I joined in November of 2019, expecting a nice reprieve from law firm life and getting essentially Medicaid crisis for the bulk of my time at the state. But something Alan said, I think resonated, which is that NEMT as the New York State Medicaid director, where we spend upwards of $1 billion a year on NEMT, was, I would say, viewed as a line item until we really started digging into the problem. When I inherited the Medicaid program, it was a program in financial distress. And so we were looking at all aspects of Medicaid spend to think about where we could deliver better value for Medicaid members. And NEMT quickly rose to the top of that pile. And so I had the privilege, while in Medicaid, of moving our NEMT model, which is largely a carved out benefit, from a manager to a broker model, with the broker being at risk for providing efficient NEMT spending. And so really got to think through traditional value-based healthcare problems in the NEMT space. At the same time, we were expanding the Medicaid program's commitment to NEMT, which was just recognized through the CMS approval that New York State received in early 2024 for health-related social needs, and the ability for transportation as one of the 3 critical components to people accessing health-related social needs that are designed to address their social determinants of health. And so that goes to your point, Scott, about NEMT being a real driver of getting people to care and services without which they're not going to succeed in getting healthier. And then the last element, just to touch on, is that, and it's something that Alan mentioned too, the technology possibilities that we're seeing right now in the Medicaid NEMT space are enormous. When I was in the Medicaid program, we were dealing with Metro cards, and hopefully we'll talk a little bit more about that. But as we move more to ticketed rides, the ability to expand all forms of NEMT, including public transportation, through enhances in technology like Omni in New York City, make this, I think, really a space where there's tremendous ability to recognize new value that hasn't existed historically. So that's tremendously exciting. And so with that, I'll turn it back over to you, Scott.
No, that's awesome, Brett. It's great to have you here. Moving right along, let me introduce Keith Passwater, who is the CEO of Havarti Risks. Keith?
Thank you, Scott. Appreciate that. Glad to be here. I was the chief actuary of Elevance Anthem, and while I was there, we were overwhelmed with cost of care savings ideas. A few of them had great possibility, and the rest were complicated and noisy. I left there and started Havarti specifically for the purpose of looking at new innovations like MediDrive that could generate significant cost of care savings, but within a health plan, it's just very hard to innovate around a solution like this. So I'm really excited to be here on the webinar today.
Welcome. And last but certainly not least, we've got Cal Milligan, the Chief Revenue Officer at MediDrive. Cal, over to you.
Hi, thank you, Scott. So again, hi everyone. Cal Milligan here, Chief Revenue Officer here at MediDrive. I bring over 25 years of experiences in NEMT, in the NEMT industry. I started in being a transportation provider for 15 years, and I can tell you, Scott, I saw firsthand the impact that transportation has on members and their health outcomes. I can recall taking members to dialysis, going in, they're healthy and strong, and you pick them up 4 or 5 hours later, and the impact of how drained and how they look, or I remember missing their ride. So I can tell you firsthand what the impact does. I've been at Motive Care prior to joining MediDrive for 10 years. Came up the ranks, started as a manager within the New York operation, and rose to the ranks to end my time there at Motive Care as the vice president of the Northeast region, overseeing the transportation market. So a lot of years in the NEMT space, and it's a pleasure to be here today to give you some insights.
Cal, that's awesome. I really I admire that firsthand experience that you bring. So great. Let's jump into our topic now. I've got a number of questions here to ask. Alan, I'm going to start with you. We're all aware that social determinants of health is a hot topic or hot topics. I've heard several NEMT companies talk about the impact of transportation on SDoH. How important do you feel NEMT is to SDoH?
Yeah, thanks, Scott. And obviously, I really appreciate you starting with me. No, listen, I think it's incredibly important for many reasons, right? We talk about going upstream in healthcare. We talk about the risk transfer and so forth. But if we really concentrate on healthcare and the journey that, pun intended, probably, the journey that people go on through their healthcare, most of the experience they have with a doctor's office or a hospital or a facility starts with them getting in a vehicle, right? You know, unless you're living in New York City or some urban area where you can literally go around the block. And even then, trust me, I'm in New York City today. Getting around the block is not that easy. So you're starting with this journey. For a lot of people, they might be able to afford that journey, right? But for a good amount of people, that journey is complex. Whether you're relying on public transportation, you're relying on friends, you're relying on family. And so the ability to come up with some trusted form of transportation to and from your care is absolutely essential. And the other thing that I think is really important, Scott, when we think about social determinants of health, is the cultural differences and how people both look at transportation and look at healthcare. So an understanding of the local geography, the local circumstances people find themselves in, is also really essential. What will work in Austin, Texas will not work in New York City and may not work in Albany and may not work in Nashville. So it's really important that as we think about the social determinants, that we can really think about the connectors and how we get people to those connectors. One good example, I think, and Brett, you referenced this, I'd love to hear your thoughts on it too, is the 1115 waiver in New York with the social care networks that the Medicaid program is now pursuing. And Scott, and for the audience, that's where New York is asking for community-based organizations to become the hub of a network that can draw in Medicaid recipients and really focus on their social as well as their healthcare needs. One of the key components of that is transportation. And the ability for that social care network to contract with a transportation company that, quite frankly, is specific to the individuals, the culture, and the community within that kind of relatively small social care network. So, Scott, if we're going to be successful, not only do we need to be considering what that social and community is, we also have to think about the technology and the way we interact in order to provide them safe, reliable, personal transportation that can actually get them to the care they need.
Great insights. Brett, did you want to jump on there? I know he referenced you. Do you want to add anything there?
No, I think actually Alan described it really
Perfect.
well in terms of, but it is, I would say, a unique challenge with regard to that form of transportation services versus general Medicaid NEMT, because in that waiver opportunity in particular, and we'll see how it's modeled in other states that have large social care spending programs in Medicaid, that the expectation on the part of the social care network is that community-based organizations are the primary providers of the transportation services, as opposed to traditional livery, ambulette, and other providers. And so I think it's a unique challenge for entities that have to manage NEMT spend, because the identity of the transportation providers in that space are going to be a little bit different. And so I think it's a really good example of where even within Medicaid, the different programmatic spending buckets can impose different requirements, which increase the complexity of how to manage this benefit.
Gotcha. Thanks for adding that, Brett. Keith, given your background as an actuary, do you think NEMT can actually help decrease healthcare costs?
Yes, Scott, I don't have any question about it at all. We spent some time looking at the numbers. I'll mention this later. I was actually surprised at the magnitude, but it's reasonable to see a path to saving $10 to $20 PMPM. And you might ask, well, why would that be? I know coming in from the health plan side, I probably didn't give this nearly enough attention. I thought, well, it's a nice benefit. I just didn't realize that for Medicaid enrollees and even Medicare Advantage members, as we said earlier, you have enrollees who just decide they just can't get there. And so that foregone visit, and in the case of Medicaid, we think about maternities, that turns into, in some cases, premature births, which are substantially more expensive than on-term births. And I mean, we're talking about the financial, Scott. I know where your heart is. I'm more concerned about the impact to the families and the child, right? So if we can provide transportation, it gets that visit in, and we reduce the number of preterm births, we save money, as well as do something good for our population, which at the end of the day, I think is why really almost anybody in Medicaid is trying to make it work financially. But I don't have any question about the economics working from an actuarial perspective.
Awesome. And Brett, you've had, as we stated, a long history with Medicaid, including a very senior position in New York State. Specifically, what's your experience been with Medicaid recipients in transportation?
Yeah, I mean, it's a really good question because I think the answer to that and thinking through this question is really one of integrated care. And New York, I think, and this was a policy decision that I inherited, which was to keep carving out the NEMT benefit from the larger managed care benefit package. And Keith's response, I think, highlights that, which is the way that states have thought about NEMT is how do we provide the most cost-effective mode of transportation based on the individual's need, right? Is that public transportation? Is that shared livery, individual livery, or ambulette, right? And that's how people would think about the spectrum of services. But really what that's missing is if you provide on-time and efficient NEMT services to an individual accessing care, then we create better health outcomes because you don't have missed appointments, you have people remaining in drug treatment programs, you have people delivering care in the right environment, and you're avoiding emergency care. And New York, I think, made a mistake in the sense of carving out NEMT first from its mainstream Medicaid managed care plans and then from its MLTC plans so that it could manage the total spend under sort of an NEMT specific risk model. I think the real value in NEMT is exactly what Keith mentioned, which is the real cost savings you're going to receive are those that create NEMT as a component of an integrated Medicaid program that recognizes the total cost of care for that individual. So we have that, in New York, the only product that has that now is PACE. And actually some IDD programs, right? So you can kind of find it in different components. But I think ultimately with the waiver, I hope the proof is in the pudding in the sense that we're going to recognize better and lower healthcare spending as a result of better integrated NEMT into the care delivery model. And if I were an SCN on the waiver side or an NEMT broker on the non-1115 side, really trying to pay attention to where better NEMT care delivery results in causable and actionable healthcare spending reductions, and then to bring the benefit back into it to an integrated model.
Thanks, Brett. So, Alan, based on Brett's response, what can be done to improve the reliability and the experience of the Medicaid patient, and what they should expect from their transportation provider?
Yeah, Scott, and I appreciate Brett's comments. And by the way, I was as surprised as Keith was when it came to the financial impact that I would say well used and coordinated transportation benefits can have on the medical cost. And Keith, I would say it's not just NEMT, it's NEMT that is handled correctly all the way down to getting the reliability to the member that will drive that cost savings. And feel free to challenge me on that. Yeah. So to answer specifically, Scott, the question, I think, as I've come into it, and I look at the way MediDrive is set up, MediDrive is and that's my experience in transportation, MediDrive is a transportation company that is applying all of the logistics understanding of transportation to the healthcare space. That's a little different than I think other companies. Why is that important? Well, not only in order to drive reliability, do we have to understand a patient's journey, a doctor-physician's journey, a health plan's journey. You also have to understand the driver's journey, the transportation provider owner's journey, as well as all the technology that can and should go into coordinating each component of those different journeys. So if I think about let's say a traditional NEMT company, I'm thinking them coordinating the benefits, and then saying to transportation providers, here's the trips that have been requested. If we think about where we are in the modern world, that is missing a tremendous amount of technology interfaces that could drive a far greater experience for the patient. So as I look at what we've built and how we're approaching it, every one of the journeys I just mentioned, we have not only mapped out, but we've created a vertical infrastructure in order to drive reliability at every single stage. So I'll start with, obviously, the drivers, right? So we look at the drivers, we credential the drivers, we make sure they're trained on wheelchair accessibility, getting people into the vehicles. But more than that, we need to know where the drivers are with GPS locations. We need to know the driver's schedule and when they have openings in their schedule. So we're not only routing that driver for tomorrow based on what those trips are, we can also have a look at where issues, traffic patterns, accidents occur, reroute and put a different driver in there or a different vehicle. So at the end of the day, that patient, the one who's trying to get to the care, is not worried about who or when they'll show up. They know that a driver is going to show up and that they are being communicated with consistently so that they can get to that doctor's office. And if you think about all the different aspects in those journeys, Scott, that go into that, that is a very complex set of vertical infrastructure that has to exist. We also have looked at the provider. Those providers are booking appointments. They don't necessarily want to then turn around to the patient and say, figure out how to get there. So we've also created software that allows the provider to book a trip for the passenger, for the patient, so that all of that is coordinated too. Once you wrap both of those and others into the NEMT benefits you're managing on behalf of a managed care plan, a Medicaid plan, you've now created this incredibly reliable vertical stack that is transparent across the entire continuum. So whether you're a care manager, you're a provider's office, you're the patient, you're a caregiver, a care coordinator, everyone is looking at the same infrastructure that is creating that incredible reliability. And it exists, right? We've created it. I just don't think, to some of the points we've made, that necessarily the health plans out there know it exists or understand the application and impact it can have to the patient's outcomes and, quite frankly, to their medical loss ratios.
That's excellent, Alan. Yeah. I'm going to pivot. Cal, I'm going to come to you. You have the longest experience working with NEMT, as I understand it. MediDrive is essentially a broker managing your own internal drivers and vehicles, as well as national group of independent transportation providers. Given that, what can you tell us about the best practices of working with this group of transportation providers and how you assure the performance of these providers so that you can maintain really high service levels of service?
Great question, Scott. First thing I would say is I communicate to my transportation provider network that, hey, we're not moving packages. And if you consider them to be packages, our packages talk back. They will call, they will complain, and they need to get to their appointment. So that's the first thing off the top that I communicate. The second thing is being transparent, right? Being transparent with our transportation providers of how much trip volume you may get, what are the client's needs, right? What are the SLAs, on-time performance, no-show rates, and so on and so forth. And last but certainly not least, what are the reimbursement rates, right? If you're cutting corners in the reimbursement rates and not paying your providers a healthy rate, well, you're going to, essentially the old adage of you get what you pay for, right? So we try to make sure that we're reimbursing at a fair market value to our transportation providers. But holistically, we make sure that they understand these individuals could be your mother, your father, your aunt, your uncle, your nephew, whomever it is, and you want to treat them as such. Now, in regards to how do we make sure that they are performing, right? We've created incentives, so some value-based incentives for transportation providers and our drivers. So the way our system is set up is if you're performing well, if your post-trip survey are pretty high, your on-time performance are pretty high, your no-show rates are pretty low, then you'll start to get trips first. And we'll continue to have a rolling 70 average where we make sure that based on your performance, you get served first. And if you continue to perform at a high level, you'll continue to see more and more rise. If you're underperforming, first we put you in a performance improvement plan. We have the conversation that we may have to just manage you out of our network because we cannot afford to have members miss rides, have bad service, because ultimately that goes back around to the health plan, the HEDIS scores and others, right? That affects the health plan monetarily. So to cover it up, that's what we do. We look at performance overall and how we issue and transport volume to transportation providers.
Interesting, and the built-in inherent incentive that you have. Just
Correct.
as a follow-up, Calv, how does your network scale with growing demand?
Yeah, great question. So one of the things we first look at is we try to build our network organically, right? So we go out to our transportation provider that we have contracted and explain to them, hey, we brought on additional volume that we need support on. If they have the financial resources to expand coverage area to go to acquire additional vehicles or additional drivers, and great, we'll work with them to scale that. If not, one of the great things about MediDrive is, as you mentioned before, we have our own assets. So we're able to deploy our own assets in pockets that we need additional transportation providers, where we see volume is increasing. And we do that proactively because traditionally, folks will wait for the complaints to come in. They will wait for the no vehicles are available. They'll wait for the provider no-show before they say, hey, I need to build my network. I need to scale my network. So we look at data, we analyze the data and say, okay, we've seen an additional pickup in volume in a rural area of the market, and we'll deploy our own assets if need be, or as I mentioned before, organically work with transportation providers that are in that region to expand their fleet.
Excellent. I'm going to go to Brett. Brett, what are the goals of a state like New York or others when it comes to transportation? Is it expand access or is it simply to reduce costs? What do you think?
I would say historically, and this is going to sound very cynical, it has been to reduce costs. We had a total NEMT spending number. It was, as I mentioned earlier, it was a little over $1 billion. Can we make that 10, 15, 20% less if it's a better managed benefit in terms of medical necessity and utilization and quality? The push that I think we were trying to bring to the mindset was, how do we really think about the impact of NEMT and NEMT access on overall care delivery and cost? But I would say New York, which is, I would say, a relatively sophisticated Medicaid NEMT program, was just not there. And maybe through the waiver and lessons we learned through the waiver that are designed to measure ROI impact on different new forms of spending, including new forms of NEMT, will change that mindset. But, an anecdote, and I was sharing this with Alan earlier, that I like to share from my time in Medicaid and NEMT spend, was we had a lot of discussions with the MTA because we were the single largest purchaser of unlimited Metro cards in the state. And, I was on the phone with someone very senior at MTA that I will not name. And I said to them, I was like, how, can we get a better deal on our monthly Metro cards, right? Really like direct cost savings. And what they said to me was, no, we want to charge you actually more, because when you buy unlimited Metro cards and distribute them at different Medicaid clinics, people are getting 2 or 3 of them, and they're going down into the subway station nearby, breaking the machine and selling swipes. And so your Medicaid purchasing is actually costing us upwards of $20 to $30 million a year on machine repair costs because of the swipe selling. And so one, it's an indication of there are related cost externalities of even programs with the best intentions. And the fact that when you take an NEMT program and try and just cut costs based on things like purchasing volume, you're never going to succeed. That the real lessons there are, you need to succeed in terms of access and quality, whether in the form of SLAs, whether in the form of measures like consumer satisfaction, access rise and efficiency, because doing it on straight cost is a stinker.
Yeah, fascinating. Keith, over to you. The real issue for a lot of people watching this broadcast is the cost of NEMT. So what is the cost opportunity for Medicaid plans, and what are the benefits of making that investment in NEMT?
Sure, thanks again, Scott. So when we looked at it, our actuarial team took a look at it, we thought of two broad categories. There's really a third, but two broad categories. One is cost of care, and the second one is administrative expense. On the cost of care side, and I mentioned this previously, thinking about maternities, reducing the number of preterm births, but in addition, just general admits and readmits for missed follow-up appointments. Someone should go back and see their surgeon after their discharge, but it's a pain, not really feel like going anyway. The ride doesn't show up on time, so they don't go. That is much more likely to turn into a readmission. I think we all know those are expensive. And so in terms of cost of care, you can get a substantial reduction by providing a ride and that ride showing up on time. The second category besides cost of care then is administrative expense. And so this is where an individual, there is NEMT or some ride solution, it's not working. And so that member then calls the health plan customer service line to get help. I was a little surprised, and I should have known this, Scott. That call to customer service is $50 to $150. Now you're shaking your head, you probably knew that. But when I was at Elevance Anthem, I didn't quite have my hand on that number, but reducing those numbers is really substantial. In addition, I think we all know, we must confess, those of us who were in the health plan, that's not always a pleasant experience. You know, your ride didn't show up like you expected, got this appointment, I'm pretty sure I should be there. I call my health plan. That's not often a pleasant experience. And so there's another part to this we can talk about later about that experience, but just sheer dollars, reducing that call because the NEMT solution is available and it is on time is a really substantial financial lift. All of this meaningfully offsets the cost of the NEMT solution itself.
Mm-hmm. So costs that people may not be thinking about all the time.
Yeah, exactly.
And Brett, you know, having heard Keith here regarding bad transportation, what can health plans and transportation providers do to partner with states to improve transportation and make others aware of the key role it plays if it's done correctly?
Yeah, I mean, I really think the promise in those partnerships is selling technology that states may not be aware of. And it goes to the earlier point I made, which is that even from when I started, you know, from the operational Medicaid side in 2019 to now, both the underlying infrastructure of the NEMT system, like something like Omni, versus, you know, the ability of the NEMT manager brokers' own technology has improved exponentially, you know, really at light speed. And so one thing that shocked me just going from the private to the public and back to the private sector is how little information flow there actually is between what's the innovation in the private sector versus what the public sector could know about and how to bring that technology to the Medicaid program, which is why I'm such a fan of managed care plans, is because they have a much easier way of procuring and leveraging that technology than the state does through a direct model. And so I think the best way to partner by an NEMT company and a state is really educating the state on the value of ways to leverage new technology to deal with inherent problems in the NEMT space. Is that the ability to efficiently ride share? Is that the ability to provide single ticketed rides for public transportation? Is that something Al mentioned earlier, timely credentialing drivers consistent with state requirements? Or is it something like program integrity? There has been almost no focus on transportation program integrity in the Medicaid space, and you know, how to leverage some of the tracking technologies in GPS to see whether that's being done appropriately. And so it's really an unmined space for purposes of a state's real understanding, because historically it's been extremely delegated, whether delegated through the managed care integrated benefit or delegated to a manager broker model and a single state procurement. And so states can do better. And it's really understanding where the innovations are happening.
Great, excellent points. I'm going to go to Calv. Calv, I think we've all heard that delivery of NEMT programs is sometimes challenging, spotty. People don't like waiting and don't like no-shows for services. How is MediDrive working to improve the delivery of these programs?
So Scott, I would say spotty is to say the least, right? We know that there's some challenges, and hence why I decided to join MediDrive to really provide some of the resources that I've garnered over the last 2.5 decades. Some of the things that MediDrive is doing to improve the NEMT experience is, one, the reimbursement rates. Again, it's important. I think who was it that said it? Brett mentioned, right? It's always been, hey, how can we reduce costs? And you're right, we have to reduce costs in some capacity. However, if we don't have reliable transportation, then the medical cost is going to increase significantly. So we're trying to find that. We found that fair balance where there's favorable reimbursement rates for a transportation provider, favorable savings for the health plan, to make sure that our transportation providers can have equipped vehicles, reimburse their drivers, fairly. Right? We all, for the most part, experienced after the pandemic, it was very challenging to have drivers, right? Because the cost of gas went up, salaries increase and insurance increase, time and time again. So we want to make sure that we have pretty decent reimbursement rates. Also, part of what we've done, and I mentioned this before, is having our own assets, right? Because again, we're able to deploy our own assets in areas that we see that there are challenges, to make sure that the member does not have an impact, right? When a member books a ride, they can rest assured when booking it through MediDrive that vehicle will be there, right? So those are some of the ways that we're going through this. And I think, we talk about having our own assets. Listen, there is definitely pros and there's some cons to that, right? But what I will tell you is that since we've owned our own assets and we've incentivized the drivers, we've seen that breakdowns have gone down, right? They take better care of those vehicles because there's a constant flow of work and income for them. We've seen that, our loss rate on insurance has gone down because, again, they take care of that vehicle as if it's their own because we've incentivized them to do so. So those are some of the things that we're doing to make sure that we could reassure the network of having a robust coverage to transport members to and from their appointments.
Awesome. Hey, Scott, I just want to jump in and between Calv and I add a couple of other comments to that. I think as we look at the cost of transportation on a fee for service from a health plan's perspective, we see it almost as an all-in rate, right? You've got the dollars that are transferred over to the actual transportation provider. And then you have the administrative fee, which is usually baked in, unless you're on a PMPM, that you're paying to the actual transportation broker. And so there's two aspects in there that MediDrive, especially Calv, I know we're working on. Number one is with the technology platform, that administrative cost can be drastically reduced, right? So without impacting whatsoever your driver, with the right technology, you can reduce those costs. You also have the ability that with the technology that you're having a very efficient ride. That means that the cost from the health plan is also reduced. You're not adding mileage. They're not going around different routes that they shouldn't be. They're actually getting from A to B as quick as possible. And then I think the third thing, Calv, where technology is really important for the driver is the ability to have that car filled with a passenger as much as possible, right? The one thing a transportation provider doesn't want is an empty seat in the back. And so with the technology, with the ability to make sure we can do trip inserts on demand, we can have those drivers, especially those that have a high on-time percentage and a great customer satisfaction. Our algorithms will make sure that they have less what we call dead time and that they are busy all the time. Once you combine all of that with an appropriate rate of pay, it actually reduces the costs on a fee-for-service basis. And so I think that's a really important when you bring in the experience of a transportation company that has been doing this for 40 years and you match it with the healthcare experience, you start seeing some of these real underlying patterns that can be fixed.
So, Alan, you triggered a thought for me, and that is, the transportation benefit is only valuable to those who need it, and are actually using it. So, from what I understand, what I've seen, the transportation benefit offered by many health plans is grossly underutilized. So, I got to be hard on you. Here's a three-part question for you. Why? Why is that? Why should health plans be concerned about that? And what can be done about it to increase the usage of transportation?
Yeah. Well, I think if we think about some of your opening comments, Scott, right? We said 1 in 5 appointments don't occur because of transportation issues, right? So I actually think in Medicaid, there's studies out there that it's almost 35% of respondents say that they don't go to routine appointments because they can't get transportation that is reliable. So we then flip to what Keith had said. Somewhere in the range in Medicaid of $22 PMPM is the opportunity cost that Medicaid health plans are facing because of that 35%, maybe it's less, maybe it's 1 in 5 of appointments that aren't happening. And you get all these downstream impacts as a result of it.
Mm-hmm.
Versus, let's say on average, it's $5 PMPM is the cost of the benefit. Maybe it's a little more if you're incentivizing that benefit to be used. I think the point that we're saying based on the actuarial research, and Keith, you can jump in here, is the actual cost of a well-run transportation benefit is completely offset by the reduction in medical costs that it occurs as a result of that increased benefit. So I think one of the first things, Scott, that as we work with health plans, we want to make sure that we both are educated on is that transportation actually should be used as an enabler of better outcomes and cost reduction versus a standalone cost unto itself. I think that's really important because health plans have an incredible ability to educate their membership. I also think the ability to promote that lies, quite frankly, with the physicians and the doctors, right? We know, especially as health plan leaders, the one thing that a patient will do way more than listen to their health plan is listen to their caregiver, right? How many care management programs have we all been in where we try to call the patient and the patient says, I'm not picking up that phone from my insurance company. They probably want me to pay a bill, right? Even though we don't make those calls, that's the reaction. And so the ability for an insurance company, a Medicaid plan to partner with a provider's office to educate that provider's office on why the benefit exists, how it can be used, and how the provider's office can get involved with using transportation with software, I think would go a long way to smoothing out both the reliability, the understanding, and the ability to promote that it exists and it can be used reliably.
Yeah, I just want to jump in. Sorry, Scott.
Okay.
On that, it's both, in some cases, members are not aware that the benefits available, but even when they are, word of mouth travels. And so some years ago, I was working with a health plan that was offering transportation service for a Medicare population. And the doctor's office itself observed that they would make the call, the ride would show up late. There's evidence in the Medicaid population as much as half the time the ride shows up late. It doesn't take long for everyone involved, the patients and the clinicians, to say, maybe you want to think about another solution here. It's a short step then for the member to say, I'm just not going to worry about it. I don't have time to chase this thing down today. So ride reliability is critical as well.
Yeah. Yeah. I just want to acknowledge you guys. We see some questions that are coming in to the Q&A. So I'm going to leave a little bit of time to see if we can address a couple of those. I've only got a couple more I want to hit. And one is, Keith, with you. When everything's working right and, we've got a well-executed NEMT program, do you believe that there's also a quality lift for health plans that's possible?
Yeah, no doubt. I mean, both in terms of the perception of the member who may fill out a survey or in some other way be asked, what do you think about the quality of the service you're receiving? That's a really painful moment when you call for a ride and it doesn't show up, or you don't have that benefit, but you've read maybe some people do. So there's that piece. And then the clinician side and patients just not being able to get to the appointment is a huge challenge to continue to deliver quality. I know clinicians in the space are really frustrated about that. Patients don't show up. Why not? If it's just transportation, and as Alan quoted earlier, it's as much as 35%. It's just because of transportation. That really suppresses the quality that the clinician can deliver.
Yeah, and I would add, Keith, that, just the CAP survey questions and, obtaining needed care and all the other accessibility issues, that can definitely have an impact as well. If members are not experiencing good service, they're going to let you know in that survey as well.
Yeah, agree.
Yeah.
And you think, Keith and Scott, you have the reduction in the provider's revenue as well. I mean, if they're booking appointments and people aren't showing up, then somewhere that balloon is being squeezed.
Yeah, another great
right.
point. Alan, CMS just issued new rules for managed care plans. And, I see a potential opportunity for MediDrive to help MCOs implement more risk-sharing agreements with providers to incentivize them around quality and standards. Do you see this as an opportunity as well, and that MediDrive can help here?
Yeah, I really do. I mean, I've worked with value-based care, various levels of risk sharing. And I think you find across the country, Scott, that there are a number of different multi-specialty groups that have different levels of risk sharing and approach transportation differently, right? So you have provider groups that rely on the Medicaid plan or the state's transportation benefit, and that isn't really delegated in a risk environment. They would have to look into it, but most of the time, even if it is delegated, they still have to use the vendor, the solution that is in place. So they don't get the flexibility to really look at their own solutions locally. And then you have others who have their own transportation and potentially could be having a 12-passenger van running around, picking up one patient here, one patient there, but they may think that the fact that it has the provider's name on the side of the van gives them a marketing opportunity. I think if you look at all of that together, Scott, there's a tremendous opportunity for a Medicaid, a Medicare Advantage, or a health plan to turn around to a provider's office that is engaged in real risk taking in saying, how do you, the provider group, want to handle transportation? And how can we, the Medicaid, Medicare plan, insurance plan, help facilitate that conversation? Because going back to something I said before, obviously, Scott, at the end of the day, that the folk who have the greatest ability to coordinate transportation are the people who are making the appointments in the provider's office. If Scott Law has to be at a provider's office a week from Thursday at 3 p.m., let's have the person who's scheduling that appointment for Scott Law next Thursday at 3 p.m. also say, do you need help with transportation? And if the answer to that is yes, then here is your benefits. Would you like us to coordinate that transportation for you? Right there and then, you've taken away so much noise. And with the right technology, if that patient is worried about the transportation coming, if perhaps they think it's late, that provider's office can see the vehicle. They can see where it is, and they can help the patient understand what's going on, or their caregiver, or the technology that a company like MediDrive has. So from my perspective, Scott, I think there's a tremendous opportunity for risk-bearing entities to really understand transportation, but it will take the health plan to acknowledge that more needs to be done to give control.
Thank you. Thanks for sharing that. I think, yeah, we've got time here. I'm going to move to some of the questions from our audience here. Renuka was asking, what states is MediDrive serving? So either Cal or
I'll take that. So
Yeah.
MediDrive is available in all 50 states. If someone is interested, I think we're going to be providing some contact information post this call. Please reach out. We'd love to have a conversation with you and see how we could assist you in your transportation NEMT needs.
And Cal, just as a follow-up, a part 2 here, says having your own network sounds like a pro, but is there a con to that? Prices being passed through to the client, insurance, maintenance, versus a traditional broker model where assets aren't owned, but rather subcontracted?
Yeah, so I think there are some cons. However, what we've looked at over the last couple of years is that the pro outweigh the cons, right? So we're able to assign vehicles to drivers. They take these vehicles home. They know that this is their, how they're going to make revenue, how they're going to make income. So they take better care of those vehicles. And I think I touched on this earlier. It reduces the wear and tear on the vehicle because they're more inclined to take care of the vehicles. We reduce the insurance rate because they're not looking to have an accident and be out of work. So there are some cons, but we've done our analysis and shown that the pros definitely outweigh the cons on that aspect.
Yeah, and I just want to jump in there, Scott. MediDrive's proprietary network is not just on vehicles. Yes, we do own fleets of vehicles, but we also contract with third-party transportation providers. We will contract with ride-sharing apps as well, although that tends to be more on a continuity of care basis or a place where a health plan specifically wants them. So what's great is we get the experience from owning our own vehicles, and we understand how drivers think, but it is definitely not an exclusive network in terms of the way that works. And one of the other huge advantages that I think, Cal, maybe you can talk about is having our own proprietary own fleet of vehicles does allow us to put cars and other transportation types in places where there may not be transportation resources today. Right. So I see there might be a question on rural impact. If there is no transportation provider there, there's not much you can do. But if you have control of a fleet, you can certainly move resources around.
Yeah. So Alan, let me elaborate a little bit on that. So, those areas is what we'll call transportation deserts, right? Not a lot of folks, not a lot of infrastructure, not a lot of transportation providers. The fact that MediDrive has its own assets, or we have contracted with independent operators, we're able to dispatch vehicles to those transportation deserts to service members that live in these rural counties. So that's definitely a plus for us. And we've definitely made that one of our selling points to let health plans know, if you're having service issues, give us a call. We'll be able to solve them for you.
Guys, let's do one more question before we enter into our closing here. This one is for Brett. It's from Howard Berkowitz. Do you expect healthcare plans to add more MA plans in 2025 and beyond with transportation added benefit?
It's a great question. I can speak most specifically to the New York experience, and the answer is for fully integrated plans like FIDE or HIDE SNPs. New York, it's called Medicaid Advantage Plus, is the FIDE SNP version. The answer is no. While I think there's going to be a greater recognition of adding the benefit because of the potential for NEMT to generate overall cost savings, similar to what Keith mentioned earlier on a PMPM basis, we just moved the benefit out in Medicaid. And, it's not a direct benefit for Medicare. So I think at least for New York's experience, we're going to see NEMT running on a parallel structure. I'd like it not to be, and I think the state will come around to that. But again, I think it's moving from the sense of, can we just manage the direct cost versus thinking about it as part of a holistic care delivery and benefit model, which, I think we're going to see gravitating towards.
Thanks, Brett, for that insight. So, ladies and gentlemen, I certainly can't speak for all of you, but I think this has been a great session. As we come to a close, Alan, Cal, I know there's an MHPA 24 coming up conference in Indianapolis on September 11th. For those in the audience who might be attending, what have you got to say to them?
Cal, if you want to go first?
Yeah, I'll get to the point, right? So for me, I say, looking forward to seeing you guys there. Please approach the booth. We want to have some great conversations around NEMT and the benefit and how, MediDrive could help you with your overall OpEx expense regarding transportation. I think Alan touched on before is, by having the proper technology, how we could reduce some costs for you. We have a great network. We have great technology. Looking forward to have the conversation and hope to see you there. Thank you.
Yeah, and Cal and myself will be there. And from my perspective, Scott, I think I would ask folk, please stop by and be incredibly open-minded about the potential that NEMT can have on your organization. And most importantly, with both technology, network, and the overall approach, how we can help to improve the outcome and the happiness of your membership. Because at the end of the day, that is why we all are doing this, or should be doing this, is so that the population is healthier. And I'm certainly hoping that we can demonstrate the impact that we will have.
On that note, I'd like to thank everyone, all of our attendees, our esteemed panel, MediDrive. I think it's been a great discussion and appreciate everybody's participation. Thank you. That concludes our presentation.
Thank you all.
Thank
Have
you
a
so
great
much.
afternoon.
Thank you all.